My name's Simon Chowdhury. I'm a medical oncologist working at Guy's Hospital and the Prostate Centre in London. I specialise in the drug treatment or systemic treatment of prostate cancer, largely locally advanced or metastatic prostate cancer. We've just written an article on new drug developments in metastatic prostate cancer for Trends. I was going to give you a brief overview of that and pick out some of the highlights. So metastatic prostate cancer is sometimes underestimated because the initial treatments for it of lowering testosterone or androgen deprivation or castration, be that medical or surgical, works in the majority of people, works in over 90% of people, and works for on average 12 to 18 months. So it's a very active first treatment. But I think in some ways that's been a great advantage, but also a disadvantage in that perhaps it's make us take our eye off the ball with regards to patient treatment. So there's been a lot of work over the last 5 to 10 years looking at the tumour biology of prostate cancer and seeing what we can do to improve outcomes for men with what is a lethal illness. The first, and I would say the most promising breakthroughs were discovering that the androgen receptor is still the dominant biological pathway even when men progress after this primary androgen deprivation therapy. We used to call this disease hormone insensitive or hormone refractory disease, and that was actually a misleading term because it made us move away from androgen receptor targeted treatment. What we know now with new research is that the androgen receptor is still dominant in the majority of those men, and that's led to the discovery and development of two particular drugs, abiraterone and enzalutamide. Abiraterone is a drug that lowers testosterone levels even further. It's an androgen biosynthesis inhibitor, and it ultimately leads to what I would describe as supracastrate level lowering of testosterone. What we've seen with that in landmark studies, which have largely taken place globally, but with a lot of patients put in from the UK and from UK centres, is significant improvements in overall and progression-free survival and licensing of the drug in that situation in men with metastatic prostate cancer who are failing primary androgen deprivation therapy. These are really significant breakthroughs. Enzalutamide is a drug that also blocks the androgen receptor pathway and blocks actually the interaction between androgens and the androgen receptor. So it's a new anti-androgen developed from an older one, bicalutamide or Casodex, that you may be familiar with. Enzalutamide again has shown in landmark studies that it has a significant improvement in overall and progression-free survival. And both of these drugs, which are oral drugs, are well tolerated, have really changed what we're able to do for men with prostate cancer. So these men are living longer, with less symptoms, still contributing in and out of work. The other significant breakthrough that's recently come through was presented in May 2015 at the American Society of Clinical Oncology meeting by Professor Nick James from Warwick University. This is a UK study called the Stampede study, which looks at systemic therapy for newly diagnosed hormone-sensitive prostate cancer with men with locally advanced or metastatic disease. And this is a complex study that looks at several arms compared to androgen deprivation therapy, which has been the standard of care for these men. The top line news from this study was that adding chemotherapy in the form of docetaxel for 6 cycles given over 18 weeks significantly improved overall survival for men. For all comers, it improved overall survival by 10 months, but for men with metastatic disease, it improved it to 22 months, so from 43 months to 65 months. I believe this is a study that will change practice and will lead to docetaxel being used almost routinely for men with metastatic prostate cancer who don't have any contraindications to that. So we can see there's been some real big shifts in what we're able to do. Other drugs that are coming through are radioisotopes such as radium-223, immunotherapy, which you'll have seen a lot about in the news. One of the first positive immunotherapy studies was with Sipuleucel T or Provenge, which is a vaccine treatment not yet available to us in Europe. But I think that gives us a signal that immunotherapy will play a role in the treatment of metastatic prostate cancer. So in some ways, where does that leave us as clinicians treating men with prostate cancer? Well, it leaves us with new options, and with new options become new choices and new challenges. Some of those challenges are sequence, which drug to use when. There are challenges in terms of toxicities, new toxicities from these treatments, and challenges in terms of patient selection. It also leaves us with changes in terms of what happens to men who progress after, say, abiraterone or enzalutamide, where the androgen receptor is being targeted and we've got what I would call very hard androgen receptor blockade. Are we seeing new changes in the treatment of prostate cancer? And I think we are. We're suddenly seeing men with liver metastases, brain metastases. And how are we going to treat those men? The other thing that's very important is cost and how we use these drugs in the most efficient manner. There's challenges certainly for all health systems, and one that we're getting to grips with in the UK. NICE have recently ruled that enzalutamide for pre-chemotherapy patients isn't going to be supported, and I would challenge that, because I believe this is a very significant breakthrough for these men. I believe it's something that should be available to our patients in the UK, and I think as a prostate cancer community we need to look very hard at where the resources are going. But that's one that I'm very disappointed that we haven't taken forward. So those are the challenges as I see them, and I think as a community what we need is prostate cancer specialists, urologists, oncologists, tumour biologists, radiologists, pathologists, clinical nurses, and very much involving general practitioners as well. A lot of these patients are going to live for significantly longer periods. We need to work with all of our colleagues so they understand these drugs and also understand which patients need to come back into specialist centres and at what time. So that's how I see the development of prostate cancer. Very exciting and interesting area, and one where we're going to see further developments over the next 5 to 10 years.